Só um segundinho, eu gostaria, antes do professor Chukuka iniciar a conferência dele, eu queria fazer uma apresentação do professor Chukuka. O professor Chukuka é fisioterapeuta de formação. Depois ele partiu para uma atividade estudando colágeno. É um grande especialista na área de colágeno. E, posteriormente, começou a trabalhar na área de laser, né, de fototerapia. E hoje ele é uma figura extremamente importante. Ele já foi presidente da Sociedade Mundial de Laser Terapia, da WALT. Atualmente é o editor em chefe da revista Photomedicine and Laser Therapy, ou seja, é uma das mais importantes revistas e é o órgão oficial da WALT. E ele tem uma gama de trabalhos extremamente importantes na área de laser, de fundamentação de laser, da fundamentação da fototerapia. É um grande especialista com um renome internacional. Então, gostaríamos de agradecer a presença do professor Chukuka entre nós e desejar a vocês que se deleitem com uma boa palestra dele. Obrigado.
Thank you, Nevado. Good morning, everybody. Bom dia a todos. I don't speak Portuguese very well, so I'm going to give my talk in English, and I hope you don't mind. I was told that somebody gave his talk in English yesterday, so I won't be the first one to address you in English. But I will try to be slow so that you can follow along. Because the topic that you're addressing today is one that has been of concern for many people in the field. And in particular, those of us that receive articles from different parts of the world, many times we are not so clear what parameters have been used in the studies, and at times you ask the authors to explain this, and they are not so able to do so. And the reason is because there has been a proliferation of devices on the market, and most of the devices are not the same, they're different, and the format in which they come also are different, as you can see in all of these different devices that are now available in North America. In fact, even more recently, we have now therapeutic devices that are not just applicators like that, but they come in big parts in this manner. Moreover, the technology has advanced so much, and so we have microprocessors determining what the user should do. So most of the devices are automatically controlled by the microprocessor. So, and then we now have a combination of wavelengths, such as in this illustration here showing the combination of 660 red light with infrared 880 diodes. These are all LED diodes. So this is a very timely talk. So for this presentation, I will start off. I've actually done the introduction. We'll just now start off with the dosimetry. And in addressing dosimetry, I will look at 4 factors. The first one is the factor determined by the machine. The second one is the factor determined by the end user. And this end user means the clinician that is going to use the machine, or the researcher in the laboratory, or anybody that uses the machine. And then we'll look at light-tissue interaction, some of the effects that could have on dosimetry, as well as the patient factor. For clinicians, you worry about, you really want to know how the patient's condition would affect dosimetry. And then we'll look at treatment parameters, the choices that could be made as far as the machine is concerned, the choices that could be made as far as treatment is concerned. And then we'll then look at the limitations and the challenges that we face as far as this issue of dosimetry is concerned. And then we'll try to bring it to a close. Hopefully I can do this in 40 to 45 minutes, but I'm not so sure because I would prefer to have a lot of time for discussion, question and answer, than for me to talk and talk all the time. So let's start off with dosimetry. And then in this area, we'll start with the machine factor. Most people know that that power and power density are very significant issues, and they differ from machine to machine, but they do affect treatment in terms of duration and things like that. And there are important factors as well. And the size of the applicator that comes with the machine, whether the applicator is very small, such as, for example, my laser pointer here has a very small aperture. If I point it to the ceiling, you can see that it makes a very small impression on the ceiling. But there are devices that are very large, and so we have to look at how that affects dosimetry. Then we have the beam profile. The profile of the beam is also very important. As you know, the beams can differ from one machine to another. And we look at the pulse or continuous mode of light emission. In terms of power density, I'm sure everybody knows this very well. It is simply dividing the average power of the machine with the area that is irradiated by the machine. Therefore, and then in terms of continuous output and pulsed output of the light emitting device, continuous output, the power stays virtually at the same level throughout the treatment, whereas in the pulsed mode, the device is on sometimes and off sometimes and on again and off again and so on and so forth. So the average power in this case will be less than the average power in the previous case where the power level is steadily at the same level. The average power here will probably be somewhere at this level because it's pulsating. Okay. Just to give you an idea, if you had an area this size that is being irradiated, again, power density simply means taking that whole area, in this case 100 square centimeter is what I assume this to be, and then you divide by the total power of your machine, which in this case we assume is 500 milliwatts. And if we assume that this is 100 centimeter, each unit here is 1 square centimeter. And therefore, in this case, if each unit is 1 square centimeter, then your power density is going to be about 50 milliwatts per square centimeter. This is a very simple concept, but it gets more complicated when you begin to look at other factors. Okay? When you consider that machines come in different sizes, the devices come in different sizes. If the applicator is 1 square centimeter, of course, all of your 500 milliwatt power is going to be concentrated in this small area. Therefore, your power density is going to be 500 milliwatts per square centimeter. But if the size of the applicator is bigger, is 2 times this size, such as in this case where we have 2 square centimeter, then this is going to be divided by that amount of area and your power density becomes 250. Therefore, as the size increases, the power density itself decreases per square centimeter. Again, this is a very simple concept, and I think everybody understands that. But it gets more and more complicated. For example, if the size remains the same, but then you have different devices with the same size, 2 square centimeter. If one device is 100 milliwatts average power output, then in that case, the power density is going to be 100 divided by 2 square centimeter becomes 50. But the more the power of the device, the more the power density is going to be. So that, for instance, in device number 5, where the power output is 500 milliwatts. Then if you divide by the same size, your power density is 250. Again, there is a relationship between the power output of your device and the area that is occupied by the beam. So the bigger the area, if the power remains the same, I have to go back here. If the power remains the same and the area gets bigger, your power density decreases. If the area remains the same and the power on the machine has different power, but the size is the same, then, of course, your power density, again, is going to increase with the increase in the average power. Very simple factors. So now, another machine factor, I think I went back on my slide. Probably didn't. Machine factor, we've talked about power, now we'll talk about the aperture and the size of the applicator. Okay. And then we'll talk about beam profile, and eventually we'll talk about pulse versus non-pulse. If you look at the aperture of this device, it's very small, whereas the aperture of this device is very large, and this is even larger. If they all have the same power output, obviously the power density is going to be very high here compared to that or compared to that. It even gets worse when you look at a situation like this, where the same machine, this is the machine here, has two delivery systems. This machine has a probe that delivers 1,000 milliwatts. And the size of that probe is 5 square centimeters. So in this case, the power density is going to be 1,000 milliwatts divided by 5 square centimeters, in which case we have an average power there of about 200 milliwatts per square centimeter. The same machine has a device right here that delivers 6,500 milliwatts of power. But we know, because the size of this applicator is very large, trying to remember what it is, but it turns out that the average power density here is only 13 milliwatts per square centimeter, if you do the mathematics. So yes, we have more power, 6,500 milliwatts, compared to 1,000 milliwatts, but the power density is very low here, because the applicator is very large. All 6,500 milliwatts coming out of this machine is being spread over a very large area, whereas the 1,000 milliwatts from here is only being spread over 5 square centimeters. These factors have to be taken into account in treating the patient. I have to go back to this slide, because you need to know also, as most of you are clinicians, I understand, so you do need to know that, for example, if you are going to treat a very large area, you might be better off with this type of device, in which case it saves you the time of treating one small area and then moving to the next small area and then the next small area and so on and so forth. But the treatment is going to take a longer time because the power density is very low in this large device compared to this. Okay. Let's take a look at beam profile. And this is where there's a lot of problems. Because the type of devices out of which we get the light vary from one device to another. They could be laser diodes, they could be LED diodes, they could be even polarized light or ordinary light. But in terms of beam profile, it turns out the concept we just covered here, you could actually apply to a beam such as this here. Here we have a beam being emitted by a device, and with a spot size that has a radius of 1.5 millimeters. Okay? And again, using the formula that we discussed earlier on, you could actually calculate the power density of this beam. Because if the output from the machine is 100 milliwatts, if the radius is 1.5 millimeters, you could use that formula and derive and arrive at the fact that the area of this beam is just 0.07 square centimeter. Okay. And if you divide that power by the area, and you get the power density, and if you multiply by time, let's say 30 seconds of treatment, then your dose becomes 43 joules per square centimeter. Again, very simple concepts, but it gets worse as you look at the profile of different devices. All of them are really uniform like this. You can see here the beam is fairly uniform, and the beam is quite evenly dispersed in this case. However, it is not always like that. You could have a beam that is shaped this way. It isn't round. It is ovoid in shape. And not only that, it even gets worse. You could even have a beam where the average power is not evenly dispersed over the spot size. For example, in this device, most of the power is concentrated here. And the output in these regions are significantly lower than it is in this region, in this beam. So it gets, as you move away from the center, the power diminishes significantly. So if you were treating an area that is this size, it isn't necessarily true that the power being delivered over the entire area is the same. It is not, because the power from this machine is so concentrated in this little spot that most of the areas covered by the device, the spot size is not actually receiving the full intensity or the power of the machine. So we have a problem here. The preferred beam profile would be a device, for instance, that emits light, and the power that is being emitted is evenly dispersed over the entire area, the entire size of the aperture of the device. But that's not what we have. Most of the laser devices we have today are mostly devices wherein the beam is concentrated in the central zone of the spot size. For example, if I shine this on the ceiling, you probably take a look at it and you find that right in the center of the beam, the light is very, very intense. But on the periphery of this beam, the light is not intense. It's less intense. And that's what we have with these devices. So then it becomes a problem to calculate the power density of this device. For example, in this case, where is the edge of the beam? Would it be right to say that the edge of the beam is right here or right there? But we do know that the beam spreads out as far as the eye can see. And in fact, disperses all the way around. So it becomes a problem to calculate that. Depending on what we assume to be the edge of the beam in this case, then the calculation we're going to derive will be different. For example, if you take this device again, you find that you have two radii. You have a radius in this direction that is smaller than the radius in this direction because the beam is ellipsoid in shape. So radius 1 is about, let's say, 2 millimeters, and radius 2 is just about 1 millimeter. We can actually determine the area covered by this beam using this formula over here. If you do that, you find that the area of this beam becomes 0.06 square centimeter. And if you plug that into the equation, what you find is that, again, that's what you get if you use this now. But if you take into consideration that this beam spreads all the way out there and all the way out there, if you use the radius at this level from there to there, and from there down this way to where it ends over here, you're going to get a different value. The radius is going to become 0.12 square centimeter compared to 0.06 square centimeter. And depending on which of these radii you use to do your calculation, you're going to get a different value in terms of the power density or the energy density. You get, for instance, using this, you probably have 48 joules per square centimeter, whereas you have 25 joules per square centimeter using the other radius. So you can see that you almost have 50% more power density, energy density, in this case, compared to the previous case. So depending on what we assume is the radius of the beam, the calculation could be different. Why do we worry about such small amounts of light or such small differences? I think that's the reason you're having this meeting today. The reason is because, it is because it significantly affects the measurement of the beam, of the output of the machine and so on, and it also affects the accuracy of dosimetry. Now it gets worse because most of the machines on the market are so different. They don't even get the type of profile which is very nice, nicely shaped as we have here. The profile is so different. And it gets worse. As a matter of fact, I have a little device in my bag that if you shine it, if you turn it on, you don't see any particular spot. It just spreads all over the place. So with such devices, how do you calculate the power density or the energy density or the dose that you're deriving from the machine? It becomes really very difficult and very complicated because the output from different devices differs significantly and they come in all forms and shapes. Just as I showed you earlier on. Then it even gets more complicated because here we have, in this device, for example, we have several diodes. Each of these diodes emits light that is targeted to a particular point. For example, if you look at this device here, you see the red diodes, the lights that are coming out of the 4 red diodes can be identified in terms of where they mark the spot size. Now you have 32 infrared diodes in this device, 32 of them, each of them creating a little spot within the beam profile. And here we have replaced the red diodes with 4 blue diodes, and you see the same thing happening again. Therefore, if we were treating a patient with this device, and you apply the light on the patient, you're going to have 36 spots, individual spots that you can identify coming out of the light from this applicator. So the beam is not evenly dispersed. And it becomes very difficult to really calculate the dose. Remember the slide I showed you earlier with the beam profile, and we are not able to determine the exact edge of the beam? Now, the machines come with dose calculators. The devices on the market today have dose calculators, and those dose calculators use mathematical algorithms to determine the dose. If the clinician chooses a particular time, duration of treatment, the machine automatically computes the dosage. And the machine knows the power of the machine. It also knows the power density of the machine. And so when the user chooses the duration of treatment, automatically the machine uses this type of algorithm to calculate the energy density. Okay? But then the question is this. What type of area was used in computing or preparing the algorithm that the machine is using? In other words, when the manufacturer prepared this dose calculator, what area was used? Was it the area or the size of the applicator, or was it more than the size of the applicator? Because the beam it's not just limited to the size of the applicator, and the beam is so different from one machine to another. So those calculators, you just have to be very careful with them. You almost have to, on your own, prepare your own dose calculator if you're doing research. If you're doing patient care and treating patients, this is not too much of a problem because of some of the things that I'm going to cover later on. But if you were doing research with these devices, then you probably want to recompute your own dose calculation. Let's take a look at the end user factors, the clinician or the researcher or the person that is using the machine. The choice of machine and machine parameters becomes very important now that you know that the machines all come in different forms and the beam profiles are so different. It becomes very important that if you are choosing to buy a device, that you check all of these things out and make sure you have a device that will meet your needs and that is also functionally easy to use. Then we have the situation where the end user or the clinician either uses the device in the contact mode or in the non-contact mode. And then, of course, we have different modes of treatment and different durations of treatment and frequency of treatment. How often the patient is treated. Sometimes 2 times a week, sometimes 3 times a week, sometimes every day. So all of those factors determine the dose. And I think I have to be careful here because there is a concept that we haven't even talked about. And that's the concept that it isn't just the dose that is delivered per day or per treatment session that is significant. Another significant factor is the total amount of energy that is delivered to the patient over a period of time. So if the patient is treated for 1 week, 4 times a week, compared to 2 times a week, using the same dosages, the total amount of energy is going to be different. So the more treatments you do, the more total amount of energy. The less treatment you do, the less total amount of energy if the dosages are the same. Okay? Then another factor that comes in here, in terms of mode of treatment, is whether the energy is delivered in very large quantities. For example, it is possible to deliver 30 joules. 30 joules, total joules, to a patient in 1 week. You could do it twice a week, 15 joules on Tuesday, 15 joules on Thursday, total is 30. Or you could do it in 3 treatments. On Monday, 10 joules, Wednesday, 10 joules, and Friday, 10 joules. And you could do that, and you still have 30. Or you could treat only once a week on Wednesday for 30 joules. And now you can see that each of these is going to have a completely different result. So you can see there are so many factors involved. This is just a cartoon showing the contact mode where the applicator is in contact with the skin of the patient. And you can see this illustrated here by my friend Toshio Shiro of Japan. And then this is the non-contact mode where the device is applied from a distance to the surface of the skin. And in this situation, you have a problem because not all the beam applied coming out of this device goes into the tissue. Some of it is reflected in all directions. So you actually lose energy in this situation compared to the previous situation. Even when a device such as this white plastic device is used to space the distance between the applicator and the skin, you still lose energy because some of the light beam will be irradiated from the side of this spacer. So in summary, this non-contact mode is not good because you are going to lose energy. As much as possible, it is better to have the applicator directly in touch with the skin. Let's take a look at light-tissue interaction. As I said earlier on, we have so many devices out there, lasers, LEDs, polarized light, light-emitting diodes. And then, of course, we have the factor of wavelength. Wavelength becomes a factor because depending on the wavelength of your device, the interaction with tissue is going to differ a little bit. And then the power and the beam profile, we've already talked about that. And then, of course, there are other factors. In terms of whether the device is a laser device or an LED device, if they are all of the same wavelength, then the main things you need to consider that differ are just coherence, mostly coherence, and the spectral width of the beam. where with the laser, the coherence is very high, and the coherence is significantly reduced in your light-emitting diodes and your superluminous diodes. They're actually much less than it is for the laser. And the bandwidth, the spectral width of emission is very narrow with the laser. In fact, the way to remember this is to think of the helium-neon laser, for example, where the wavelength is where the wavelength is 632.8 nanometers. And it's so precise that we know that the wavelength of that laser device is 632.8 nanometers. It isn't 633, it isn't 632. It is 632.8 nanometers. And of course, with the gallium arsenide laser device, for example, we know also that the beam is 904 nanometers, very precise. Whereas with the LEDs and the light-emitting diodes, superluminous diodes, you have to really take a few additional steps for them to be that precise. In fact, the beam is usually very broad in terms of coherence and spectral width of emission. So the bandwidth is wide. A device such as this with 650 nanometers wavelength could have a range from 635 to about 670. But most of the beam will be 650. So you have that difference between them. But with mirrors and optical devices, you could actually get this to come very close to being like that. Wavelength is important because it turns out that depending on your target tissue, you may want to choose a wavelength that is going to penetrate the tissue more than the other wavelength. So the longer the wavelength, basically the longer the wavelength, the more the depth of penetration of the device or the beam. In general, the longer the wavelength is, the more the depth of penetration. Some people have tried to, I just want to use this to illustrate the fact that sometimes people assume that because the longer the wavelength, the more the depth of penetration, therefore the red light, say 660 nanometer light, and some have come up with the idea that it penetrates just 1 centimeter and the infrared goes to 5 centimeters. This used to be very popularly taught to clinicians in the United States. But this is garbage. This is wrong because you can actually prove it wrong fairly easily. If I were to shine this through my finger, you can see for yourself that this little device, just 5 milliwatts, passes through this thickness of my finger and just goes on like that, passes through various thicknesses of the finger. Therefore, and this is more than 1 square centimeter. 1 centimeter. So the red light wouldn't be limited to 1 centimeter. It actually goes deeper than that, and that goes deeper than that. But the problem we have is we don't have accurate data on how much the depth of penetration is for different wavelengths of light. And that becomes an issue in determining those. So some people have tried to increase the depth of penetration by buying machines that have more power. Of course, the more power the machine has, the brighter the light is going to be in the tissue. But I'm not so sure that you could actually then enhance the depth of penetration with the power. You probably are better off doing so using longer wavelengths. And of course, the coherence of the beam, which differs. So when you have beam that is not really coherent, the waves are going to go into the tissue at different rates and at different speeds, and you won't have a very good outcome. Whereas if the beam is coherent, the waves are all uniform, parallel to themselves, and they penetrate a little better. I'm going to skip this slide. Then comes another factor here, light-tissue interaction now. Here we have a laser device, diode device with very precise, coherent, collimated beam. And we have a superluminous diode device where the beam is not as collimated as it is for the laser device, and the beam spreads out fairly well. But then you apply both of them to tissue, and what happens? The beam gets dispersed in the tissue in all directions. In all directions. Again, I can illustrate with this. If you look at my little device, I think the light is too bright there, but you can see for yourself. This little device that will make a single, very small spot size on the ceiling, in the skin, it just gets dispersed all over. This could have been a pure laser device that is highly coherent, highly collimated. But once the beam gets into the tissue, it disperses all over the place. So those of us in the United States have raised the question, is it necessary, absolutely necessary, to have a laser device? Or does the LED or superluminous diode produce the same result? This continues to be an issue that is continuously debated in the literature. If you follow the work of Tina Carew, you know that Tina Carew has, and others have said that, look, it doesn't seem to make a difference. But Carew is now coming up with the notion that coherence might actually result in different interaction pattern with the tissue. So that, and no one knows whether that difference in the interaction pattern with the tissue actually makes a difference in the result, in clinical outcome. Again, just to drive home the point, I have a little video here to show you. We've been doing some studies on ulcers, and I'm sorry that this particular ulcer doesn't look so good. But if you look at the video, you see for yourself that very clearly the applicator is right there. That's the edge of the applicator. But the light has illuminated quite a lot of areas all around the wound. So if we are going to calculate the dose, do we use the size of the applicator as the area? Or do we use the total power of this machine and divide by this whole area that is illuminated in the tissue? Again, these are some of the questions that are being raised by a number of individuals in the literature. So that it isn't an easy task. Basically, it is not an easy task to determine dose, because in determining dose, you have to define your area, whether it is the area of the applicator or the area of the tissue that is illuminated, or even the volume of the tissue, because that becomes another factor, the volume of the tissue that is illuminated. Here is another ulcer that we've been treating for some time now. This ulcer, I show it because this is a very deep ulcer. It is a very deep ulcer. This pair of forceps that you see here, you see another one there. In the course of treating this patient, I put that forceps into the ulcer, and the forceps could actually touch the calcaneal bone of the patient. So that tells you how deep this ulcer is. So in the course of treating this patient, how do we determine the dose of light reaching the deeper portions of the ulcer? How? How do you define the dose? Is it the same intensity of light at the edges of the ulcer, around there? Or is it less deep into the ulcer? Again, you can see that different tissues are going to receive different intensities of light in this situation. So let's go through that. Here is a paper. This actually is taken out of a paper submitted to the journal by Rachel Lubert of Israel, of Bar-Ilan University. This is just ordinary light. This is white light. And you can see that it is white light if you look there. But when you turn this light on, the power is very high, by the way. You can see it's white light, but it passes through your hand. It illuminates almost the entire hand. So the light covers quite a big area. Not only that, notice the change in the color of the light. The light that was just white light illuminates the hand, and all you see is red. And some have actually reported in the literature, and I believe it comes from the group of Bagnato in San Carlos, that when the light gets into the tissue, the wavelength doesn't stay the same. That when the light interacts with the tissue, there's some effect on the wavelength of the light. And we're waiting now for some people to come up with some more reports in that direction. So we don't know. Once the light hits the tissue, a lot of things change. So it isn't the same beam, that the same light characteristics and profile that you knew before it hit the tissue. It becomes a little bit different. In the US, the National Aeronautics and Space Administration, NASA, has been doing some research work with light, and they've been using light-emitting diodes for their research. And as you can see, these diodes illuminate the skin, but then you can see the individual spots occupied by the diodes. And but basically, again, the point is, when you apply this type of device to the patient, you can see you are losing a lot of energy because some of it doesn't even hit the patient. And it isn't adapted to the contour of the skin or the surface of the patient. We are about 15 minutes. I'm going to take another 10 minutes and so I can have time for question and answer. The other issue is the therapeutic window. In this case, we're looking at wavelength of light. And if you look at the literature, what the literature points to us definitely is that for tissue repair and pain reduction, that we tend to stimulate a lot better with wavelengths ranging from right about 600 nanometers all the way to about 1,000 nanometers. So this seems to be the consensus of everybody now in the field, that for tissue repair and for pain reduction, stimulation is best achieved in that zone. So we know that. And then for bactericidal effect, obviously you can get a whole lot of bactericidal effect with ionizing radiation if you wanted to. But if you want to preserve the tissue, the patient's tissue, and not destroy the patient's tissue, you could destroy bacteria better with blue light and UV, but you're safer with blue light than you are with other forms of light. And in the United States, it has now become very popular in the field of dermatology and in the field of aesthetics and cosmetic surgery to use yellow light, gold-colored light, or yellow light, for skin rejuvenation. Approximately 580 nanometers wavelength is what people are using. So let's go now to consider patient factors. The patient factors, I think we've already covered some of them. The type of lesion, whether there is swelling. If there is edema, you have a lot of fluid in the region, and the fluid is going to absorb some of the light, particularly your infrared radiation, a lot more than your normal tissue would. So again, that's another factor to consider. The skin color becomes important. The darker the skin, the more the attenuation of the beam, the less goes through. Okay, so that's another factor to look at. And then the site of the lesion, whether we're dealing with bone or dealing with soft tissue and things like that. I'm sorry that I keep showing you all these pictures that are not so pleasant to look at, but here we have one of the ulcers we've been treating for some time. This ulcer has a tunnel that goes in. It's like very deep inside, and it's windy. It curves in a different direction. So if we apply our beam on this ulcer, are we reaching the deeper tissue, the injury deep inside the ulcer? Chances are that we are not. Chances are we are, but we are not sure. We don't know. And the same applies to this one. And of course, depending on your applicator, you may have to do multiple sites at a time. You treat one area, another area, and so on until you cover the area of the ulcer. We can control some of these factors. We can obviously control some of the factors. In particular, we can depending on the patient's factor and depending on the choice that you make, you might get a better result. For example, if your lesion is very deep inside beneath the skin of the patient, it makes sense to choose a longer wavelength to treat the patient. If there's a lot of fluid in the area and you know that the light is going to be absorbed a whole lot, it makes sense to raise the dosage, the fluence that is going to be used. So there are a number of these factors. About 4 years ago, Pekka Pontinen and I came together and wrote a small book. It's a very small guide to clinicians how to choose dosages for different conditions. That book is still very popular, and unfortunately I didn't bring any copy with me, but it's a very popular book, and it's very simple to use. It gives you the guidelines, and it also explains what you can do to adapt to different conditions of the patient. Okay. So, in summary, the factors that limit accuracy of dosimetry is that we cannot predict how the light would interact with the tissue. A lot of models have been developed out there and published out there. But these models are not easily adaptable to clinical situations. And the type of interaction between the light and tissue would depend on the type of tissue, the type of lesion, whether it is chronic, whether it is acute, and so many factors like that. Plus, the data we have on depth of penetration of the devices of light is a little not so clear. We have also minimal data on beam attenuation. If we apply light to the tissue, and we know what the power density, energy density is on the skin, what is it every square millimeter, every millimeter down into the tissue? We don't know. We don't have much data on that. And then we need more data on dosages for different conditions. We don't have enough of that. Things have gotten better, but we really don't have enough of that. So in conclusion, I would say that trying to accurately determine dose is like trying to walk on a tight rope. And you see people try to do this, many people fall. You know, over time they fall and they are not able to do it. But the question that comes to mind is this. Do we need a high degree of accuracy? Do we need a high degree of accuracy of dosages in clinical practice? I ask this question because, as you know, in clinical practice, people are getting good results without necessarily taking all of these factors into account. They just use a certain dose range and they get some positive results. But at the same time, I have to point out to you, this is the reason the literature is very confusing. Because somebody else will take somebody's result from a particular group of patients and apply it to another group of patients, and the result is no good. And when the result is not good, then there's conflict in outcome. But the conflict in outcome may be explained by these factors. The patients are different. A patient with edema is going to respond differently from a patient that doesn't have edema. But do we need a high accuracy? And how are we going to achieve that? It doesn't even seem like it's something that is easily achievable. Let me show you a few slides, and you see, for example, why this becomes a very important question. Here we have, this is my famous slide about cells responding to light. Here we have a situation where, this is a research situation where the cell is in a Petri dish, and this is a fibroblast in a Petri dish, right there. And this is infrared light, and is being pulsed and pulsed like that. Notice that the light is not being applied to the cell. The light is not being applied to the cell. The light is being applied to the medium away from the cell. Okay? So, does the light have to be applied directly on the tissue or on the target that you're trying to apply the light to? If you watch this video, you see that the light doesn't have to be applied to the fibroblast because the fibroblast can detect the light and migrate to the light. So, do we need to apply the light? Do we need to be that precise? Even in situations where we have two sources of light, the fibroblast still knows that there is light there and migrates to it, and it in fact knows that there's another second source of light and migrates to that second source of light. So it raises that question, do we need to know? Here's a different situation where the cell was migrating in this direction. All of a sudden, they put light there, the cell goes back to the light. So certainly with this type of laboratory result, it becomes clear to me that maybe we don't need to be this accurate. Maybe all we need is just to have the light as close to the site of lesion as possible. This is a topic that could take a very long time to discuss and talk about. We have spent already about 45 minutes. I'm going to stop here and see if we can take questions. But in case you want more information, you could actually get it from our journal, Photomedicine and Laser Surgery, which comes out once every 2 months, 6 times a year. And I'm very happy to report that when we checked the publications from different parts of the world last year, in October last year, it turned out that 2 years, in 2005 and 2006, we received more papers from Brazil than anywhere else in the world in this journal. So obviously many of you are doing a very good work here. And I will say muito obrigado. Okay? Yeah. Thank you. I will leave you with a slide of our campus as I take questions from you.
Agradecemos aí a bela apresentação com uma série de questões importantes. A gente abre para os questionamentos da plateia.
The question is, you see, we all know that dosimetry, precise dosimetry in laser therapy is impossible. Because you point out very clear all the problems, and even if we can, even in the same regions will be different, so yes, we'll be in trouble there. But the problem is that now people don't have directions what to do. So some people think that dosimetry is what the people that produce the device is telling them to do. Just calculate the area and that's it. Yeah. And then when they read some paper or something, comes that people say, well, I applied such an energy per square centimeter, and don't even say if that is related to the applicant device or if it is something else.
Yes.
So we are worried that because of this diversity of, we would like to understand why, and I think we are understanding. It's too many parameters, it's too many variants, and we cannot possibly deal with all.
Yes.
So we'd like to reduce the problem to a few parameters that everybody could speak about. Yes. And it's clear what you show, that we don't need a lot of precision, but we have to talk the same language. So if we have to reduce dosimetry to 3 parameters, what would that be in your opinion?
Okay, that's a very difficult question that you're asking me. Because as you know, there are so many differences of opinion in the field. But it seems to me that it is fairly simple to know that I have a device. The device has an aperture, let's say 10 square centimeter. The device produces 100 milliwatts output. It seems to me very simply that I could just, from a very simple way of calculation, determine that 100 milliwatts divided by 10 square centimeter gives 10 milliwatts per square centimeter. That's my power density. And what is all left for me to do is to calculate how much time I use the device. If I turn it on for 10 seconds, 10 square centimeter times 10 seconds gives me 100 millijoules per square centimeter. Very simple, no complication, no difficulty determining this. All the other factors becomes moot in this case. In particular, if I'm going to treat the patient with direct contact with the skin, I would say. But having said that, it has to be reported that I would prefer to see a paper in which the author reports that they reduced it to this simple approach. However, this may not be the exact dose. It may not be the accurate dose, but it is a simple, straightforward. So everybody else can now know that that's where, at least that's the basic fundamental value that they took off from. Anything else, we cannot tell. So I will go with that. And use energy density, the fluence, as the basis of dosage. The fluence, I believe. And then, so there are two things to report. It is calculating the fluence using the method that I just described, and reporting also the total energy, total amount of energy delivered to the patient. Those two I would feel comfortable with. That's just my opinion.
What about the distance between applications?
The interval between treatment?
No. So the distance, like suppose you show many devices.
Yes, distance from the
they are too
applicator
much
to
different. But if we somehow give the dose on the application plus the distance between the points we choose,
to
then
treat.
we
Yeah.
somehow cover everything, no?
That has to be, that I'm assuming that is already known. That that if we have an area that is being treated, that we already know that the entire area has been illuminated. Or that if the applicator is very small, that the researcher or the clinician took time to treat every square centimeter of that area. It isn't enough, and I have seen reports in the literature, even to today, appearing in the literature, where somebody is going to treat, let's say, osteoarthritis of the knee, and they treat 4 spots all around the knee. One here, one there, and one from behind. That's garbage, total garbage. That's not going to cover the area effectively. So I assume that the area has to be defined and all the area has to be treated. Yeah.
I have a question about, we discussed here about the lesion, but if you have acute lesion, you have to treat it quite different way when you have a chronic lesion.
Yes.
Because in my experience here, basically we treat acute. Well, preferentially, I prefer to start when the patient comes out of the OR.
Surgery, yes.
Exactly.
Yes.
Then we start in this way, and I think that this is the best way that you could treat.
Yes.
But in case that you have to treat acute lesion, I think that you need to see some. It's quite easy, to be honest with you, because it's a quickly way, because it seems that all the phases that we have for inflammatory phase are very clear, and then you have just go, and the light can help a lot.
Yes.
But we are going to a chronic one, then we have a different situation. And in my experience, it's not so much, but we start to have some situation that we want to close the lesion, and sometimes the wounds start to be worsening. Well, is there other ways that you can just follow and try to see if your amount of energy, it's not so much that instead of you have reparation tissue, you have the opposite way?
Yes, yes. You're absolutely correct. I'll give you 2 examples. In the book that I referred to, we suggested to clinicians that if they have acute lesion, to start off treatment with maybe 3 times a week, and then as time goes on, reduce to twice a week. We suggested that. I have personal experience in the lab and also in the clinic of having treated, for example, in the laboratory situations when we dealt with collagen and collagen production. When we treated animals every day, it resulted in production of collagen every time the treatment was done. So when you do the biochemistry, what you find is that the cross-links are very immature. You have a high proportion of immature cross-links and a very large proportion of highly matured cross-links. And when you reduce the treatment to 2 times a week, you don't have a very large proportion of immature cross-links. All you have is a very large proportion of mature cross-links, indicating that the less frequency of treatment might be better in this situation. Okay, so obviously, acute versus chronic has to be treated differently. And it is possible to treat too much. Certainly possible to treat too much. In fact, the way I explain this to everyone is that if you were asked to take your, let's say, I don't know what pain reliever is popular in Brazil, but in the United States, aspirin. If you were told to take aspirin, 1 tablet 3 times a day or maybe 2 times a day, let's say 1 tablet 1 time a day. If you take 3 in 1 day and take it every day like that, that's not good. The same thing with light. If you put too much energy every time, it's not good. We have to remember that this is the same device that could actually become a surgical tool. It's used in surgery, can destroy tissue. So,
and in order just to try to find some border, just to stop the treatment, well, I was looking for some ways that we just could go through. And I found that the pH could be some ways that you could guide.
Yes, I heard about your studies with pH.
Well,
and I heard about that already. And it's very interesting because I actually found it very fascinating because there are people that believe that you should monitor the pH of
the
the
literature
tissue.
is there. Some
Yes.
people are just
Yes, you should
studying.
monitor the pH of the tissue.
Is there someone that is doing this with?
No, I don't know of anybody else except your
Okay,
group.
because I was looking for. I was just trying to
No,
get
only your
it.
group. You are the only one doing this now.
Okay,
Yes.
because I was just looking for the
No, I
Germans.
don't know of anybody else that is doing this. But I do know that people, I have to correct myself. I do know that people monitor pH and temperature.
Yes, we are just going this
in
two
wound,
ways.
in a pressure ulcer, in pressure ulcer and bed sores. This is very important to monitor the temperature and the pH of the ulcers. Yes.
I would like to come back to the dosimetry, as you talked about, a little bit more about the area that is being treated.
Yes.
Because we know that there is a systemic effect of the laser therapy, and all these differences that we have in treatment in every day, every week, or something like that have to do with this, I think. And we have somehow yesterday had a lot of talks, and we have accorded some language things that we think are a consensus between our group here. And one thing that we have agreed was that it was important to report the total energy that we furnish to the total area that has been treated. And that the points that we use to treat the lesion should be apart, like the same area that the beam covers in each. You had an image here with those little spots. And there is a quantity that you use it to this that is called safe. I don't know if you are aware of it. It is safe, a spatial average energy fluence that you use the total energy and the area. What do you think about that?
Dr. Bayat told me that he has a device that he now has developed for spreading the beam evenly so that we don't have this problem of beam just being spotty. So maybe that will help. And this safe, I'm not familiar with it. What is this device?
Safe. No, it's not device.
Okay.
It's a quantity.
It's a quantity.
It's the way to represent the energy.
Okay, yes.
Instead of giving only the superficial delivery energy,
Yes.
we give one extra information.
Okay.
But
And that extra
we
information.
can show you this.
Okay.
Number of points that you
Treated,
in a special area,
Yes, I see.
a particular area.
Yeah, yeah.
Uh-huh.
Okay. So that gives you the average for the area.
Yeah.
Okay.
Yes.
That's important.
When we are going this direction,
Yes.
it seems more fine. just
Yes. To
have
give
the
that
same-
extra information. That's correct. Yeah.
I was interested in your mention of the wavelength
Yes.
change. Is there any evidence for that, and how big of an effect?
How much change
Yeah,
once the light hits the tissue?
yeah.
There is evidence in the. There's actually a paper. I think it came from your group.
No.
It wasn't you, but it came from Brazil somewhere. I thought it came from San Carlos. There is a paper. There's a paper. I'm trying to remember his name. The first lead author of this paper is from this country. It talks about how the wavelength changes once the light hits the tissue. I have the reference in my computer. I could actually pull it
So
up.
how
for you.
big is that effect?
It's a very small change. It's not very much.
So is there any biomedical significance, or is
We,
this just
we don't
tiny?
know. Just additional information.
Okay.
The wavelength, yeah. I think that is my paper from Salati. Do you remember? In
Yeah.
photomedicine.
Yes. Was that your paper?
Yes.
Okay. But I know it came. I knew it came from San Carlos.
Yeah.
And I thought it was your
I
group since
changed
they asked
the
to do it.
wavelength.
Yes.
And the effects was different.
Okay.
Yeah.
Yeah. Okay.
Yeah, but see,
No, that's different from what I'm talking
not
about.
The wavelength changing during. So if we
Is
send
the wavelength
if we
changing?
send a monochromatic light to a tissue,
Oh.
you know,
No,
I
no.
think there is a small
There's a
misunderstanding.
small
Okay.
change.
Yeah, we have one
Yeah.
paper that's concerning to the distribution of wavelength when you're using the LEDs, like
Yes.
how the wavelength distribute and things like this. Not light shift. It's not light shift.
Yeah.
Okay.
The shift is what I'm talking about. That
Okay,
there is a
so
slight
Yeah.
shift.
Okay.
Yeah.
do you observe light shift?
And the
No.
only analogy I can give to this is that, for example, if you were to put a filter in this light, if you put a red filter, you get a predominance of red light coming after the filter. If you put a blue filter, you get a preponderance of blue light. So it seems to me that the way I relate to this is that maybe the tissue somehow acts as a little bit of a filter, that you get a predominance of a different wavelength from what you put into the tissue.
I would like to congratulate you for your presentation.
Thank you very much.
I'm from the laser laboratory at the USP, São Paulo University.
Good.
And my worry is about the distribution of the points in the tissue. I think is the problem that we are facing now. In my opinion, if I know that the laser have a little spread in the tissue, I suppose that if I put points too close each other, I can have an over irradiation of the energy.
Yes.
So in my opinion, I agree with you. Like if I use 1 centimeter square,
Yes.
would be better.
Yes.
But I know that it's difficult to calculate the 1 centimeter square for area. So in your opinion, can we use like at least 1 square centimeter in each point, or I should put more space between the points? Depends of the area. Like in the industry, use small areas. So sometimes when you radiate an after, for example, after ulcers, I see that in red light, I using the one point, but I see this spread out of the tissue.
Yes.
So in this case, in very little lesions, can I use like 2 points just? Or I should use 3 or 4 using more area than the lesion?
Yes, I understand.
Around the lesion. Sorry for my English.
No, I understand your question very clearly.
Thank you.
I think this is a situation where, as a clinician, you have to make the judgment yourself based on what you see in front of you. If the light irradiation is very intense all around, maybe there's no need to do more than 1 point. If it is broadly intense, if it is intense but local, and then you don't have too much all around, then maybe you can do 2 points.
Oh, okay.
This is just
we can see in the
matter of
clinician.
common sense here, I think. Yeah.
Okay, thank you.
And this is part of the problem that, that we're talking about. Because if you have too much intensity of light all around, and you do 2 or 3 locations, you can actually over-irradiate some of the tissue.
And have inhibition of the effect.
And have inhibition. Yeah.
Thank you.
You're welcome.
Okay. Thank you for your presentation.
Well, thank you very much. And have a, thank you. Yeah, thank you.
Nós vamos ter a palestra agora do professor Alex Vitkin. Ele é do Canadá, da Universidade de Toronto. Ele está muito envolvido com aspectos da interação